Today is World Sepsis Day, 13 September. So I'm going to discuss with you chasing procalcitonin biomarker in early sepsis diagnosis and prognosis, race against time. Let's see how. So definition of sepsis, or definition for the term SIRS or systemic inflammatory response syndrome, sepsis, severe sepsis, or septic shock have been proposed by American College of Chest Physician and Society for Critical Care Medicine Consensus Conference in 1992. And this definition is now widely used. If we see the terms SIRS or systemic inflammatory response syndrome, two or more of the following criteria like temperature more than 38 degrees centigrade or less than 36 degrees centigrade, then heart rate more than 90 beats per minute, respiratory rate more than 20 breaths per minute, or arterial carbon dioxide less than 32 mmHg, white blood cell count more than 12,000 cells per microliter, or less than 4,000 cells per microliter. Coming to next definition, sepsis, when two or more of the above SIRS criteria with presumed or proven infection. Severe sepsis is sepsis with organ dysfunction, and septic shock is sepsis with hypertension despite adequate fluid resuscitation. So early 2016 new definition of sepsis and septic shock, it is defined by the Sepsis 3 task force from Society of Critical Care Medicine and European Society of Intensive Care Medicine. They launched this definition as a result of the consensus of the experts. The new definition of sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. So organ dysfunction is operationalized as a change more than equal to 2 in the sequential organ failure assessment or SOFA score. So use of SIRS criteria and the concept of severe sepsis were removed from the definition. Sepsis 3 definitions are not universally accepted by the medical community and are becoming a matter of controversy. So if we see SOFA score, it is the evidence-based clinical score for risk assessment in everyday clinical practice, used for early identification of patients with increased risk of organ failure. SOFA score is based on the degree of dysfunction of 6 organ systems like respiratory activity, CNS Glasgow Coma score, cardiovascular system, arterial blood pressure, liver function by bilirubin, blood clotting by platelets, then kidney function by creatinine. So Sepsis 3 task force also introduced a bedside index, that is quick SOFA score or QSOFA, to identify outside of critical care units patients with suspected infection who are likely to develop sepsis. So if we come to the signs and symptoms, how to recognize sepsis, it initially may look like flu, gastroenteritis, or chest infection. Symptoms may include increased heart rate, more than 90 beats per minute, then fever, shivering, feeling of very cold, above 101 degree Fahrenheit or 38 degrees centigrade, or a temperature below 96.8 degree Fahrenheit or 36 degrees centigrade. Confusion or disorientation, shortness of breath, breathing rate higher than 20 breaths per minute, extreme pain or discomfort, clammy or sweaty skin. So if we come to the major common causes of sepsis, pneumonia is the most common cause, 44% cases. Then urinary tract infection, 9.1% cases. Then intra-abdominal infection, 8.6%. Then CNS system infection like meningitis, 0.8%. Catheter-related infection, 2.2%. Endocarditis, 0.6%. Skin or soft tissue infection or infection of unknown source. So for sepsis, every minute counts. Sepsis requires immediate treatment for reduced mortality and morbidity rates. Each hour of delay in the initiation of effective antibiotic treatment increases sepsis mortality by 7.6% or around 8%. 80% death could be prevented with rapid treatment. So for sepsis, every hour counts. But sepsis, difficult to diagnose. Despite its long history and current impact on society, sepsis as a medical condition is not well understood. No universally accepted definition of sepsis. Clinical signs and symptoms are non-specific and often lack sensitivity, like temperature, heart rate, respiratory rate, leukocyte count, which we all discussed. So these are very non-specific and it lacks sensitivity. So the challenge is to differentiate sepsis from other non-infectious causes of systemic inflammation. So some common facts about sepsis is estimated to affect more than 30 million people over the world each year. So it's estimated that 3 million newborns and 1.2 million children suffer from sepsis globally every year. Most people recover from mild sepsis, but the average mortality rate for septic shock is about 40%. Sepsis results in at least 6 million deaths per year. So the majority of sepsis cases and deaths are estimated to occur in low and medium income countries. In the developing countries, sepsis accounts for 60 to 80% of lost lives per year. Hospitalization have more than doubled over the last 10 years, and mortality rate or mortality related to sepsis in US is up to 40% higher compared to annual estimates of mortality in other causes. So the average length of stay for septic patient is 75% longer compared to those hospitalized for other conditions. And septic patient or sepsis are 8 times more likely. These patients are 8 times more likely to die during hospitalization. The number of severe sepsis cases is growing at an estimated annual rate of 1.5%. So mortality and morbidity remain unacceptably high. Despite increasing knowledge about the pathophysiological pathways and processes involved in the sepsis. The number of severe sepsis cases is growing, as we have discussed, at an estimated annual rate of 1.5%. That's really alarming. The mortality rate reported was ranging from 17.9% for sepsis to 28.6% for severe sepsis. So data from Surviving Sepsis Campaign 2012 show mortality rates of approximately 41% in Europe versus approximately 28.3% in US. So coming to post-sepsis syndrome, estimated 14.1 million patients survive severe sepsis each year, but many develop physical and psychological symptoms. The common symptoms, lethargy or exercise related tiredness or excessive tiredness, then poor mobility, muscle weakness, breathlessness, chest pain, swollen limbs, then joint and muscle pains, anxiety or fear of sepsis recurring, depression, insomnia, post-traumatic stress disorder. So these are the common symptoms, and many survivors of sepsis develops physical and psychological symptoms. 1 in 6 sepsis survivors have severe and persistent impairments. Physical and cognitive decline in health is still evident at least 8 years after discharge from hospital. Up to 40% of the people discharged from hospital after having sepsis will die within 2 years, and at least 60% will be readmitted within 1 year. Survivors of sepsis are also at risk to develop complications such as diabetes and cardiovascular diseases. The economic cost, sepsis is the primary or the #1 cost of hospitalization in the US. It is responsible for nearly around $27 billion in annual costs. The average cost per hospital stay for sepsis is around $18,400. So hospital costs are currently more than twice those of other conditions, and it continue to grow. So sepsis is the primary cause for readmissions to the hospital, costing more than $2 billion each year. So coming to, we have understood that sepsis rate is alarming, it's difficult to diagnose. So because of that, lab testing or lab plays a very important role in diagnosis, early diagnosis specifically of sepsis, and also the prognosis of the sepsis in hospitalized patient. But a perfect marker of the sepsis doesn't yet exist, because sepsis is a complex disease which cannot be described by a single parameter. So what should be the characteristic of an ideal sepsis marker? It should reflect the disease severity, it should be specific, sensitive, it should be early, cost-effective, and predictive of course and prognosis. So wow, what is this? This is the genesis of sepsis marker or genesis of today's talk. So one patient who is admitted, his procalcitonin is 2 point, this is one lady, one adult female patient. Her procalcitonin is 2.1 nanogram per ml. Then interleukin 6 was done, and it was 62 picogram per ml. Then lactate was 2 millimole per liter. CRP was also raised. Pre-sepsis was done. This is not commonly done in every lab, but with so many markers. So when the patient has gone to the clinician and the report has gone to the clinician, then clinician is thinking which lab marker is the ideal sepsis marker. So if you see, these patients are coming with burden of disease, and then in lab, we use our intelligence, discipline, creativity, like what is the sensitivity of the test, what is the specificity of the test, what is the window period where the test should be done, and what should be the cutoff for the population So these are used in lab, and then patients are going out with reports. So either clinicians or patients happy with our report, or that seems to be not satisfactory. The reports may be not satisfactory as per the clinical criteria. So, and if you recognize this person can be you or me as a NABL assessor or College of American Pathologist inspector. We go to different lab and we see the process for 1 day inspection or assessment or 2 day assessment. And based on our sample audit, we see internal quality control of all the lab parameters. We see the external quality assessment or EQA scheme of all the lab parameters. And based on that, we say like the lab seems to be good. There is no deficiency or certain amount of deficiencies or non-compliance. So this is our today's lab system. If we see in sepsis, each minutes, each hour counts. So then it's very important to have the early sepsis marker. And also sometimes in many hospital setting, they may use the markers, sepsis markers, because they wanted stat reporting that can be in the lab or that can be placed in the emergency department or emergency setting. So then this is the role of the lab physician, that this instrument which is placed in the emergency setting, there should be regular each day internal quality control run, and also they should follow the EQA protocol, and they should external quality assessment should be done. So many times we see that we maintain all the quality control in our lab setup, but when it comes to emergency rooms, POC devices or point of care testing devices, we forget about that instrument. It can be either for ABG, or it can be either for lactate, it can be for procalcitonin. We follow all the guidelines in the lab, but sometimes we forget the guidelines in the emergency room setting or in the ICU or in the OT, where systems are placed like ABG and other POC device. So is the responsibility of the lab physician or lab medicine department to check the internal quality control run, frequency of the internal quality control run, and also reporting that in EQA or proficiency testing or external quality assessment scheme. Because from that POC device or from that ABG which is placed in ICU or OT settings, we are reporting patient reports. So coming to the sepsis lab testing, in sepsis, early diagnosis and appropriate therapeutic intervention can significantly reduce mortality. For a long time, standard blood culture techniques represent the only reliable tool to diagnose sepsis. Blood culture is still the gold standard, but has many drawbacks like long turnaround time, then additional a day or two for testing antibiotic susceptibility, then low sensitivity, then large sample volume, risk of false negative results after initiation of antibiotic therapy. So sepsis markers or sepsis biomarkers, so due to limitations of blood cultures, a large number of serum sepsis marker has been commercialized over past decades. Common are like C-reactive protein or CRP, which is available in most of the setup. Interleukin 6, IL-6, For COVID-19 pandemic, IL-6 is now a very common marker in lab setting. Then lipopolysaccharide binding protein, neutrophil CD64, these are uncommon markers. Then soluble triggering receptor expressed on myeloid cell 1, serum soluble urokinase type, plasminogen activator receptor, or iNOS. So these are the rare markers, but none of these biomarkers meet all the criteria of a perfect sepsis marker. So the stronger clinical evidence of clinical usefulness has been shown for procalcitonin, presepsin, but this is not again very common marker in all the lab setup. Then CRP or C-reactive protein and lactate. PCT and presepsin appear the most promising biomarkers for diagnosing of sepsis, for gathering valuable prognostic information, and for guiding therapeutic decision making. The most reliable strategy for early diagnosis of sepsis appears to be the recommendation and measurement of PCT levels for antibiotic decisions in patients with sepsis appears to reduce antibiotic exposure without worsening the mortality rate. So procalcitonin is used for antibiotic stewardship, antibiotic initiation, and most commonly for antibiotic discontinuation. So coming to procalcitonin. Procalcitonin is 116 amino acid peptide, the pro-hormone of calcitonin, which is normally secreted by C cells of the thyroid gland in response to hypercalcemia. So under normal conditions, negligible serum procalcitonin concentrations are detected, that is below 0.0 nanogram per ml. Procalcitonin can be produced by other cells like liver cells, peripheral blood mononuclear cells after pro-inflammatory stimulation, especially if there is a bacteremia. So the procalcitonin as a marker, it has fast and specific response. It distinguishes from other markers by early and highly specific increase in response to severe systemic bacterial infection and sepsis. The kinetic of different biomarkers of bacterial infections, the earliest marker is interleukin 6, then procalcitonin, then CRP. So procalcitonin improves accuracy of sepsis diagnosis. So if you see this paper by Harvard S. et al., so addition of procalcitonin in diagnosis of critically ill patients with suspected sepsis may increase diagnostic certainty and generate an improved patient management. So if you see clinical model with procalcitonin, the AUC or area under the curve is around 0.94, and the clinical model without procalcitonin, the area under the curve is 0.77. So this is 0.77, and with procalcitonin, the clinical model is 0.94. So this is highly accurate marker for diagnosis of sepsis and also a prognostic marker. Therefore, procalcitonin, if it is used with a clinical model or clinical judgment, it's a highly accurate marker in sepsis. But coming to the COVID-19, because now we know the COVID-19 pandemic by SARS-CoV-2 virus infection. So in viremia, we see raised procalcitonin, but not so high. We see the range of 2 to 5, usually we see most commonly in our patients. And because of that, we have done the study in 528 subjects and to check the sensitivity and specificity of the sepsis marker. So we have done receiver operating characteristic curve or ROC curve. And if you see in our study in Kokila Dhirubhai Ambani Hospital, procalcitonin AUC or area under curve is 0.81. So that is good accuracy. So this is a good marker for COVID-19 patient also. But if we compare this with the sepsis, in sepsis diagnosis, procalcitonin is a highly accurate marker because it's a marker of bacteremia or bacterial infection. So increased PCT indicates mortality risk for patients in ICU. So we can see if the test is negative and if PCT decrease more than 80%, so it has better prognosis. And if test is PCT is high, then the survival of the patient with PCT decrease of 80% red or high risk group, and this is the survival of the patients with PCT decrease more than 80% green or low risk group in ICU patients. So the advantages of procalcitonin is early and rapid increase in response to bacterial infection and sepsis. Then PCT starts to rise earlier and returns to normal concentration more rapidly than CRP. So earlier diagnosis and better monitoring of disease progression. Then most sensitive and specific compared to CRP for diagnosis or prognosis of sepsis. And this is a specific biomarker for bacterial infection. PCT levels are low in viral infections, in autoimmune diseases and inflammatory disorders. So this is the specific markers for bacterial infection. Now coming to lactate as an aid to diagnose sepsis and management of sepsis. High level of lactic acid caused by infections can be important clue to the sepsis. Lactate measurements, because lactate in ABG instrument, we can measure lactate. A lactate measurement has clinical and statistical significance in predicting mortality in patients with infections and is a simple strategy to effectively manage the care of the septic patients and improve outcomes. Measurement of lactate, including in clinical criteria for septic shock, defended in Sepsis 3 Task Force, third international consensus definition for sepsis and septic shock. So the biomarker kinetics like interleukin 6, procalcitonin and CRP, if you see IL-6 is the earliest biomarker. This is time course of inflammatory cytokines following surgical trauma. So time after surgical trauma, first elevated is IL-6 less than 2 hours, then PCT 2 to 6 hours, and CRP at 6 to 24 hours. And peak of IL-6 at 2 hours, PCT at 24 hours, and CRP at 48 hours. So this is after surgical trauma. Now coming to procalcitonin kinetics in bacterial infection. PCT has a rapid and sustained response to bacterially induced systemic inflammation. So PCT rises 3 to 6 hours after bacterial infection and it peaks at 12 to 48 hours. And with effective treatment, it decreases in 24 to 48 hours. And if there is inadequate infection control, so there is sustained PCT or PCT increases. So this is in bacterial infection. Now PCT levels correlate with sepsis severity. So if we see SARS, sepsis, severe sepsis and septic shock, PCT in nanogram per ml, it rises. And PCT levels according to organ dysfunction, the SOFA score and PCT is also correlating. The procalcitonin demonstrated performance superior to that of other biomarkers for sepsis diagnosis. This is done in 101 consecutive critically ill patients presented in ICU in a university medical center who are diagnosed with SARS, sepsis, severe sepsis, or septic shock. So PCT, CRP, IL-6, IL-8, lactate were measured on day 1, day 2, and day of discharge from ICU or death. So if you see, procalcitonin sensitivity is 89 and specificity is 94, and negative predictive value and positive predictive value also more than 90. Then IL-6 sensitivity is 65 and specificity 79. And CRP is 71 sensitivity and specificity 78. And lactate is sensitivity 40 and specificity 77 in that specific study for sepsis diagnosis. So coming to best practice algorithm in sepsis diagnosis using PCT. So suppose there is fever, leukocytosis, hypotension, then suspicion of sepsis, severe sepsis or septic shock. Then we should measure PCT. If PCT less than 0.5 microgram per liter, sepsis not confirmed, but there is a clinical strong suspicions, then we should remeasure the PCT at 12 to 24 hours. So if PCT is less than 0.5 microgram per liter, then there can be other causes for systemic infection, likely look for the localized infection. Then if PCT level is more than equal to 0.5 to less than 2 microgram per liter, then we should remeasure PCT at 12 to 24 hours. Sepsis, in this case, uncertain. And then if it is uncertain, check for other possible causes of inflammation. And if it is not confirmed, then again search for local infection. But if suppose this PCT, there is a sepsis confirmed, if it is more than equal to 2 microgram per liter, then search for the source of infection and consider if there is a surgical drainage needed, initiate antibiotic treatment or specific therapy for sepsis. But when we initially measure PCT, if it is more than equal to 2 microgram per liter, then sepsis is confirmed. We don't need any other markers. And then we should search for the infection and start the antibiotic treatment or do the drainage or other surgery related thing if it is required. We should follow that algorithm. Now, sepsis monitoring using PCT or procalcitonin. So some people or some center use this as a prognostic marker or monitoring marker. So patient with sepsis measure PCT, PCT level decreases by 30 to 50% per day, then remeasure PCT at 24 hours, then PCT level decrease by 30 to 50% per day over several days. That means controlled infection. Follow up every 24 hours until PCT less than 0.5 microgram per liter. And if there is a persistently high PCT or further increasing PCT level, so there is uncontrolled infection, then we should do new infection workup or adaptation of sepsis therapy and remeasure PCT at 24 or 12 hourly. So PCT kinetics provide prognostic information in sepsis. In patient with sepsis, initial PCT value, if it is more than 1.1 nanogram per ml, and there is a rapid decline to PCT less than 1.1 nanogram per ml, that is good prognosis, but no or slow decline and PCT is rising more than 1.1 nanogram per ml, then poor prognosis. So PCT kinetics in septic patients according to outcomes, if it is survived and if it is died. So there is multicentral procalcitonin monitoring sepsis study or MOSES study where there is serial procalcitonin measurement and it predicts, serial measurement predicts mortality in severe sepsis patient. So the value of monitoring PCT kinetics was demonstrated in this study with 858 adult patients with sepsis across 13 US emergency department and ICUs. And they have shown that more than 80% decline from peak values to day 4 associated with improved prognosis. So PCT can be used a marker for monitoring also. So clearance of PCT by day 4 independently predicts prognosis in patient with sepsis. So mortality was twofold higher in patients with less than equal to 80% decrease in PCT levels from baseline to day 4 versus without clinical symptoms after adjustment for maximum SOFA score or other score. So use of PCT to determine antibiotic treatment in antibiotic stewardship, and there are proposed algorithm for high acuity infections in ICU. So they have said, like for antibiotic initiation, if PCT level more than 1, then strongly encourage. If more than equal to 0.5, encourage. But if it is less than 0.5 microgram per liter, it should be discouraged. And then proposed for follow-up evaluation every 1 to 2 days. And antibiotic discontinuation, if we use that for the discontinuation, is actually majorly used for antibiotic discontinuation, PCT as a biomarker. If PCT in 1 to 2 days more than 1, then it's strongly discouraged to discontinue antibiotics. And if it is less than 0.5 or drop by more than 80%, it is encouraged for antibiotic discontinuation. And these are the PCT can be used as a biomarker for antibiotic stewardship. So this is ICU treatment algorithm, and patient admitted to the ICU with SIRS or systemic inflammatory response syndrome. Then clinical evaluation is done, then measurement of PCT and microbiological workup. And in clinical evaluation, if there is no life-threatening disease, no immunocompromised, and then evaluation of PCT of cutoff range, then if 0.5 to 1, antibiotic can be started. And if it is more than 1, then antibiotic strongly recommended. Re-evaluation of the clinical course and PCT measurement at 24 hours or 6 to 24 hours, 48 hours, and 72 hours. And so PCT is an important tool for monitoring in ICU and tailoring treatment in ICU. And suppose PCT not decreasing, then or patient is deteriorating, then consider the surgery or whatever the cause of PCT increase, and drainage or removal of foreign body or obstruction. So can PCT help to guide therapy? Earlier antibiotic discontinuation and reduction of ICU stay, length of stay is very important. So because of that, PCT is a major important marker for antibiotic discontinuation and reduction of ICU stay. ICU patients with severe sepsis or septic shock, use of PCT guided algorithm, it reduced the antibiotic duration from 9.5 days to 6 days. And also ICU stay from 23.5 days to 17 days. So PCT guided care lowers mortality rate in ICU. Now coming to Indian scenario or Indian perspective. Epidemiological data on sepsis varies depending on the origin of the database. And we don't have robust epidemiological study on sepsis. It majorly from the Western literature, Data from India are sparse and in the form of epidemiology of infection, both community and hospital acquired, rather than sepsis, which is the host response to infection. So Indian figures, whatever the papers we have, they show a higher rate of death, and newborns and pediatric patients with sepsis are noted to have 9 to 36% mortality rate, and higher estimates are allocated for patients with severe sepsis and septic shock, placing the mortality rate at 40 to 60%, with elderly having the highest mortality rate. And heightened death toll in India may result from the lack of preparedness for the sepsis cases. So there are 34% of sepsis patients in India die in intensive care unit. So for us, every blood sample tells us a story. So I believe in the philosophical line of Albert Einstein, life is like riding bicycle. To keep your balance, you must keep moving. So like in personal life, we need that balance. Then we can have smooth ride in our life. Similarly, we need to harmonize our lab life. So for harmonizing lab life, we need the smooth ride to report the patient clinical symptoms, or it should correlate with the correlate clinically. So these two wheels of the bicycle is very important for our lab life. One is a wheel of quality, and second one is a wheel of cost. Why this is important? Let me take the example of quality. Wheel of quality depends on accuracy, precision, reference interval, or cutoff. Like I said, for procalcitonin, in sepsis diagnosis, as we have seen, the sensitivity and specificity is highest for procalcitonin in sepsis diagnosis, and also ROC curve, with clinical evaluation, the procalcitonin area under curve was around 0.94 in one study. So procalcitonin as sepsis diagnosis, we should know when, what we are testing, and what is the quality control norms, like I have said, like, because every minute counts for sepsis markers. So we can place, it's not that we have to place the instrument in only in lab. We can place that in emergency department also, ED also. But quality is with us, the lab physician or lab medicine technical support team. The maintenance of the internal quality control, like how many times, what should be the frequency of running the internal quality control in the device, it depends on us. So like I have said, NABL or CAP checklist or JCI checklist that mention POCT device, internal quality control, and CAP is a separate checklist for POC devices. So wherever we place, it can be in the emergency setting, it can be in OT or ICU. The quality, accuracy, precision, sensitivity, specificity, internal quality control run, checking the internal quality control, LJ charts depends on the laboratory medicine department. Now coming to cost. To select the important biomarkers, suppose for sepsis diagnosis, to select the biomarker, the cost is important. Like I have said about length of ICU stay. We have seen in several papers that ICU stay decreased if we use the clinical criteria associated with procalcitonin. So cost cycle or cost wheel of this cycle is very important. So it depends on man, machine, and material. So we need to choose our markers so that it is cost effective and it's early and it's specific and it's sensitive. So because of that, standardization and harmonization play a very important role. Being an executive member of International Federation of Clinical Chemistry and Lab Medicine Scientific Division, under Scientific Division, there is a working group for standardization of procalcitonin. So that group is working for standardizing procalcitonin because there are variability of test results between different instruments. So this working group for procalcitonin are trying to decrease that variability and to develop the standardized reference measurement procedure for procalcitonin. Now in our lab, any parameter, it can be procalcitonin, it can be interleukin 6, it can be CRP, we should check accuracy, we should check precision, we should check reference interval or cutoff. Then we should check sensitivity or verification of analytical sensitivity. And we should check reportable range, like analytical measurement range or clinically reportable range with dilution or pre-treatment of the samples. So this is, I'll share with you the COVID-19 study done in Kokilavendra Ambani Hospital and Medical Research Institute. This is to study the role of different inflammatory biomarkers or like procalcitonin, interleukin 6, CRP in COVID-19 patients, which is caused by SARS-CoV-2 virus. So we have taken 528 subjects, and it included 370 male and 158 female, and the age group is 12 years to 93 years, median age is 61 years. And they were hospital admitted patient. And we have taken 40 healthy volunteers without any history or clinical evidence suggestive of COVID-19 infections or without any comorbidities. And we have studied the routine lab findings and the inflammatory markers, coagulation markers, then the LFT, KFT, and also the biochemistry markers and hematological markers. And here in this study, I have shown, like, we have seen elevated levels of interleukin 6, C-reactive protein, procalcitonin, neutrophil count, WBC count, and lactate is raised in COVID-19 patients. And as I have already described that, we use a receiver operating characteristic curve in COVID-19 patients between case group and control groups, the infected patient groups with COVID-19. And here in this case, we have COVID-19, actually the viral infection. And so PCT, procalcitonin, can be used as a prognostic marker. It's accurate, the accuracy is 0.81. In sepsis, like we have shown in previous study, that for sepsis diagnosis, the procalcitonin Arianda curve was 0.94. But here in COVID-19, the Arianda curve was 0.81. The procalcitonin, it's called as good accuracy. So it can be used as a prognostic marker in COVID-19 patients because there are superadded bacteremia associated with the viral infection in hospitalized patients or ICU patients. So we have taken 2 adult male patients. They are used as representatives. So if you see the several days, the case 1 and case 2, what is the trend analysis of the procalcitonin, and if you can see in case 1 it is raised, and in case 2 it is decreased. So we do the trend analysis of procalcitonin in the severe critically ill patients in ICU to use that as a prognostic marker. So I want to thank everyone here, the clinicians, emergency department physician, intensive care unit intensivists, the general physicians, and other physicians and clinicians, they are healer. They are treating sepsis patients. But if you see the extended hand, that is ours. The laboratory physicians or lab diagnostic team, we extend our hands. We give the values like procalcitonin, lactate, interleukin-6, CRP, or neutrophil count, leukocyte count. So we give the value and we give the reports. Based on that, they heal. So here I acknowledge all the laboratory medicine team everywhere. We all play a very important role, very significant role in sepsis diagnosis, prognosis, antibiotic stewardship, and also in this difficult time of COVID-19 pandemic, the lab physician role is enormous. So thank you.